Hello everyone. Today we will be going over chapter 15, Psychological Disorders. And so to start our discussion on psychological disorders, we discuss what is considered abnormal behavior or psychology. And so this is an interesting question when you think about it, because who actually determines what's abnormal versus normal behavior? Do doctors? Does society? Who actually decides this? And originally, when deciding what is typical or normal behavior for an individual to engage in, researchers actually examined what constituted abnormal behavior. So this herein lies one difficulty that we may see with diagnosing a disorder. And so although we do have this difficulty, we can compare an individual's behavior to that of all humans across all cultures and across different lifespans. And so when we're considering whether an individual is displaying an abnormal behavior, some symptoms of psychological disorders are common symptoms that everyone experiences to some degree, and so just experiencing similar symptoms to a disorder does not automatically mean that you have a diagnosis. And so when we talk about this later on in our discussion, after going through a lengthy assessment of an individual's symptoms, a psychologist would be able to determine whether or not the individual was meeting diagnostic criteria. And common symptoms everyone experiences could be just a down, depressed mood that typically lifts after a day or two at most and is related to stress or just feeling a lot of emotions about an event or someone that may be overwhelming for the individual. And so again, these are normal, typical responses that we would expect any individual to experience. And so we're going to talk about those experiences that are atypical and are less likely to occur in the population than what's typically thought and or represented in the media. So in identifying psychological disorders, the chapter discusses the common medical model that is used by physicians or psychiatrists primarily. So this model is not perfect, and we'll talk about why. So although this model is not perfect, it's better than previous models which believed people with psychological disorders were sinners, they were possessed, or they were just completely lost causes. So the medical model asserts that any disease, including psychological disorders, have biological causes, that they have a set of defined symptoms and possible cures. So the problem with the medical model includes a lack of consideration for the environment's influence on an individual, say somebody's stress level or a situation that they had just gone through, like losing someone suddenly. So the medical model is also incomplete due to the continued difficulties in delineating the specific and complete set of diagnostic criteria for every diagnosis. On the flip side, psychologists who specialize in the diagnosis and treatment of psychological disorders or psychopathology examine symptoms which include an individual's behavior, their thoughts or cognitions, and emotions that underlie the individual's symptoms. So here we talk about the classification of disorders and problems with the medical model. So the medical model suggests that understanding a person's diagnosis is helpful because categories of illnesses are likely to have distinct causes or etiologies and are likely to have a common prognosis. So how long will it last and how likely are they to be treated or cured? And unfortunately, this model is super oversimplified. And the bottom line, it's really useful to just focus on one single cause that corresponds with one single cure, especially for psychological disorders. So early classification of psychological disorders included the 20th century clinicians breaking down disorders by two categories. This included psychosis and neurosis. Psychosis is a condition in which an individual experiences distortions of perception and thought that weaken his or her grasp on reality. Neurosis is the condition that involves anxiety, but in which the person is still in touch with reality. So fast forward to earlier versions of our diagnostic manual, the DSM, These really led to unreliable diagnoses, and to address this unreliability, there was a shift to attempt to define mental disorders objectively in behavioral terms so that we can observe and assess the frequency of disorders rather than just theorizing what was going on within an individual. So the current version of this manual is the DSM-5 as we see pictured on the slide. And it's a classification system that describes the features used to diagnose each recognized mental disorder and to indicate how the disorder can be distinguished from other similar problems. Often individuals experience more than one set of symptoms, and this is related to comorbidity. Comorbidity is another aspect of the classification of psychological disorders that makes diagnosis difficult due to a person presenting with several different symptoms. People with depression, which is a mood disorder, often have secondary diagnoses such as anxiety. And so comorbidity is relatively common using the DSM diagnostic system. So why would this cause problems? If I'm a therapist and a person comes in to see me wanting help because they feel they feel down and they are experiencing panic attacks when they are around other people, why would this matter to me as a therapist? This individual may be depressed because her anxiety makes social situations impossible, or she could be anxious about being around people because she doesn't want people to see her despairing mood, or they could be totally unrelated. So diagnoses inform successful treatment of symptoms. Just like if you went into the clinic for the common cold, if they diagnosed you incorrectly and treated you for a rash, then you would not have your needs met and still experiencing these symptoms, sometimes even worsening without the proper treatment. So there are three key elements that must be present for any cluster of symptoms to qualify as a potential mental disorder. And these include a disorder is manifested in symptoms that involve disturbances in the individual's behavior, their thoughts or emotions. These symptoms are associated with significant personal distress or impairment in the individual, and these symptoms both stem from an internal dysfunction, such as biological, psychological, or both ailments. So if you're experiencing extreme sadness or distress after someone really close to you passes away, is this considered a mental disorder? As we've discussed, bereavement is normal and expected in response to a close individual's death. And so further, this doesn't originate from an internal dysfunction according to the classification of psychological disorders. This period of mourning typically lasts for 2 months. And if you go through something extremely stressful like getting divorced, losing a child, etc., the DSM would consider your elevated symptoms to last for about 6 months until they would recognize it as a possible problem. So alternative to the medical model, we have the biopsychosocial model that psychologists also work from. And so this biopsychosocial model is an integrated perspective on 3 major areas that heavily influence an individual's adjustment. So the first is biological, and this includes genetic influences if the individual has experienced brain damage or is experiencing biochemical influences or imbalances. And the second is psychological factors, and these include maladaptive learning and coping, cognitive biases, dysfunctional attitudes, and interpersonal problems. Lastly, environmental aspects are also considered in this model, and these include poor socialization, stressful life circumstances, and cultural and social inequities that we see in society. So the observation that most diagnoses have both internal and external causes has given rise to the diathesis stress model, which we'll discuss next. So more often, the cause of a disorder is best conceptualized from an integrated perspective, such as the biopsychosocial model. Biological, psychological, and environmental factors are all important. And this understanding of these influences give rise to the diathesis stress model. And when considering an individual's diagnosis of a psychological disorder, psychologists consider the following. Perhaps the individual has a biological predisposition for depression, such as genetics or hormones. Maybe the individual was raised in a home that instilled faulty belief systems like, I have to be perfect, I have to be the best at everything I do, or if not, then I'm a loser, or I'm no good. And they didn't teach you effective coping skills, and instead of coping with these faulty beliefs, you tell yourself to just get over it. You punish something or you get drunk to get over these negative emotions. And in addition to that, you happen to be under a lot of current stress. So you may be taking 15 hours during the day and you work a job at night and you get no sleep. All of these factors combined would set any individual up to experiencing elevated levels of depression. For example, whether you experience clinical levels or not has to be assessed for by a psychologist. And so within that example, I was only using depression as one particular example for the diathesis stress model. So now we'll shift to discussing more of the personal and social costs for diagnosing psychological disorders. The intervention causation fallacy assumes that an effective treatment will address the cause of the problem. So when we consider this, one example of this is that you're having trouble sleeping because you recently broke up with your boy or your girlfriend of about 2.5 years. You find out that taking medicine before you go to bed helps you sleep. After discovering this, would you conclude that your insomnia or your difficulty sleeping was caused by a deficiency of sleeping pills? No, because what we see is that the cure doesn't always point to the cause and needs to be considered in diagnosing and treating an individual's symptoms. Furthermore, when diagnosing, psychologists are aware of stigmas that are present in society towards individuals that have been diagnosed with a mental illness or psychological disorder. So when discussing stigmas surrounding mental disorders, it's estimated that roughly 70% of sufferers do not seek treatment. And so why is this? It may be due to a lack of education of the individual about their symptoms themselves. It could also be a lack of education even on behalf of the professional in the health field. So sometimes the expectations of these labels can compromise the judgment of health professionals. One study found that doctors were less likely to release mock patients who had been admitted to an inpatient hospital because they had reported hearing voices, even 6 days after they reported that the symptoms had stopped. And even then, these patients left the hospital with a diagnosis of schizophrenia in remission. And so we see even health professionals may have a stigma against individuals with mental disorders. Additionally, there's a higher proportion of individuals with psychological disorders that are incarcerated. And so researchers followed patients thought to be too dangerous to the community and found that their release resulted in no harm to the community. And several studies have actually suggested that patients released from inpatient facilities are typically no more likely to be violent than anyone else in the general public. And this goes against movies and mass media that we typically see every day and that we're confronted with every day, of even horror movies of individuals that have escaped from inpatient psych wards or inpatient hospitals. So furthermore, stigmas may negatively impact an individual's motivation to work towards recovery because they see that this is the way it may always be. Or even considering if people told you that you were not going to amount to anything, after a while you may start to believe that yourself. So this is one of the many reasons why mental health workers and professionals now refer to patients or clients as a person with schizophrenia as opposed to a schizophrenic. And so just that simple change in the language of health professionals demonstrates this different perspective that mental health professionals take about individuals that have been diagnosed with psychological disorders. So there still continues to be issues with labeling individuals with psychological disorders and a sense of dehumanizing them. So next we'll talk about the influence of culture on diagnoses. And across cultures we see different explanations or expressions of symptoms that we may see as abnormal for us, but for that particular culture, they see it as typical, normal behavior. So given this consideration, the DSM-5 includes a cultural formulation section that contains a cultural formulation interview, and the CFI includes 16 questions that the clinician asks a client during a mental health assessment in order to help the clinician understand how the client's culture might influence their experience, the expression, and explanation of a mental disorder. So when examining common psychological disorders like depression and anxiety, we find the same symptoms across all cultures, though it may be expressed differently or look different one culture to the next. And so with that wraps up the second section of Chapter 15 in psychological disorders.